Good afternoon, everyone. Many thanks for joining in. And special thanks to people who are here in person. We have Professor Duffy today, who's an academic psychiatrist. Doesn't need much introduction, but I'll still read it out. Everyone knows you. She's been here for 2.5 or 3.5 decades here in research. Okay. Oh, sorry, but it's in your profile. She's a clinical and research focus on mood disorders in young people and translating findings into acceptable and evidence-based prevention and early intervention. She's a professor in the Department of Psychiatry at the Queen's and also a visiting professor in the Department of Psychiatry at the University of Oxford in the UK. She is also the principal investigator and director of the new You Flourish Center for Student Mental Health Research, established with a philanthropic donation from the Rossi Foundation. Her collaborative multidisciplinary research has been funded for over 2.5 decades by national and international operating grants from CIHR Canada, NARSCD US, MRC UK, and several other philanthropic foundations. The work has been published in major journals, and she has been the recipient of several awards and distinctions, including a visiting research fellowship at All Souls College, Oxford. Welcome to this high-profile talk.
Thanks for coming. The few of you are here, and thanks for joining us online. So it's a pleasure to talk to you. I was talking with Paul Brock. We had dinner the other night, and I said, it's just been such an amazing journey, and I'm so thankful and grateful for the wonderful mentorship that I've had all throughout my career and the wonderful colleagues that I've had a chance to work with around the world, and all of the students who have now all grown up and continue to come through. And it's just such a huge pleasure to have this experience. And Paul and I wrote for the International Journal of Bipolar Disorders, who had a special edition on lithium recently come out, and we were asked to write a paper, and we decided that we would write about 6 decades, really his first 3 and our collaborative next 3 decades together working with families. And people always ask me, well, are you a child and adolescent psychiatrist? Are you an adult psychiatrist? Why are you in student wellness? I thought you were. So I've had this great opportunity of being a pioneer in sort of emerging fields. And when I joined, when I was a resident actually, and I joined Paul's group in my half-day protected time for research in those days, we basically worked with families, and we were looking at the genetics of bipolar disorder. And I would go around Southern Ontario with Martin Alda and interview all these family members who were adults, because we were collecting DNA for genotyping in those days. That was before epigenetics. And the adults kept asking us, you're an adolescent psychiatrist, aren't you? What is it? Could you see my children? What is the likelihood that my kids are going to develop my illness? And in those days, we really had no way of sort of individualizing the prediction for those children. We didn't really understand the emergent course. And that was also at the time that Michael Rudder was very prominent and was talking about a developmental lens and the importance of taking a developmental approach to psychopathology. And then also Myrna Wiseman had published Children of Repressed Mothers. And so it came to me that actually what I should do is study the children. And I remember Martin Alda and Trevor Young, who is now the provost at U of T. So I'm obviously an underachiever compared to my colleagues. But anyway, and they both said, well, Anne, it's not going to inform genetics because these kids aren't through the period of risk, because we were thinking about established illness in those days. And I said, yeah, but it would be, and Paul's such a free spirit and such a wonderful creative person. And he said, oh, let her do what she wants. She should study the children. It would be interesting. And so I started this 1-year project for my residency. And then it's been 25 plus years, and it's just been the most fabulous adventure and journey. And I've learned to be a much better clinician. And that's what I hope to get across in this talk, that, people say to me, well, you're a researcher. That's the other thing. And it's like, well, no, I'm a clinician who got involved in research. And it really has helped my clinical practice. So this work has been, as mentioned, funded by Canadian national, international groups, and also philanthropic foundations. I hope to go over some of the relevant background regarding bipolar disorder diagnosis, give you some key findings from our Canadian high-risk study. We call it high risk, but actually what impressed me was how amazing the kids were, either well or getting through significant episodes of illness and then really being very resilient. And I thought, wow, this is amazing. So we branded that cohort Flourish because I didn't like saying high risk all the time. And then, of course, the University Student Wellbeing Researchers then branded New Flourish. So appreciate the implications for improving diagnosis and treatment outcome on an individual basis based on this work. So in terms of background, we already know that there's a high estimated heritability. So risk factors associated with genetic factors is very high in bipolar disorders. So it's very relevant and important to study families. And I think in psychiatry, we don't really use family history in the way that we should, like, for example, cancer researchers do. A lot of our major illnesses are highly heritable. We know that it has a significant prevalence, and if you count spectrum disorders, it's higher than 2%. This is bipolar 1.2. Recurrent episodes, the classical illness has good quality of spontaneous remission, and we'll come to that, and long been associated with really antiquity with creativity. So it goes back to Hippocrates, who identified states of mania, melancholia, and paranoia as distinct illnesses at that time that were to do with the brain diseases. Fowler, then amongst others, came up with the idea that this is a singular disease in some patients where they would go from mania to depression or vice versa. And then Kraepelin, of course, with really careful longitudinal clinical characterization differentiated psychosis from recurrent mood disorder or manic depressive insanity, which included recurrent depression to a certain degree, and then angst and dichotomized unipolar and bipolar disorders, although we know that when you look at families, some family members only seem to develop recurrent major depression, and that's related to the underlying bipolar diagnosis. So it's not a complete separation. Now, we know that the age of onset, so here you can see that this is bimodal age of onset. We've also seen, another bump in very older age, but really that's organicity, so that's something different. But really, when we talk about early onset bipolar disorder, we're really talking about adolescence and early adulthood. And here's Danish data, registration data. So they have really great epidemiological data in the sense that, like our SIN number, every Danish citizen has a unique identifier, and when they access any service, any healthcare service, they are pinged in the system. So you can see then the family history, the rate of bipolar disorder is really negligible unless you have at least one parent identified in the system. And then it raises, if you have two parents, to about 25% lifetime risk. And then if you include major depression as part of the phenotype, it increases to 35%. So really, family history is the single most significant risk factor in developing bipolar disorder. So this is a really nice diagram. I love this diagram. This is from the Welsh group, Craddock and Owen. Nick Craddock, who is a geneticist. He looked at, this paper is called The Kraepelinian Dichotomy, Going, Still Not Gone, meaning that although we've blurred the boundaries over the different iterations of DSM over the years, and now we talk about all these overlapping factors between psychosis, neurodevelopmental disorders like autism, and mood disorders, really, genetically speaking, there still are two prototypical dimensions. So you have neurodevelopmental disorders and psychosis, and then over here you have the classical recurrent mood disorders, and that they're still distinct, although depending on how broad the diagnostic constructs are applied, of course, there's overlap. And so you have these genetic factors that morph into different neurobiological pathways that then morph into symptoms that we collect into syndromes. The other thing that's important with bipolar disorder is in terms of individual risk, and that question that the families had always asked us when we started this research was, what is the risk to my child? And the risk can really vary greatly depending on the family. So in some families, it looks like almost a pseudo-dominant trait. In other families, it looks like a sort of sporadic thing. And so, of course, the individual risk is going to differ in those families to that child. And so we did quite a long time ago, I guess 2000, we did a review, and that was partly from my residency review of the literature on risk. And again, found that there was still an increased risk of major depression in these families of bipolar parents. And that was really either because those people had a recurrent major depression that was related to the genetic diathesis, or that maybe had hypomania that was probably missed. The other point is that even within the same families, there's a great deal of difference or variability in how that bipolar trait manifests. So some people in the same family identified by a bipolar 1 patient, some family members will have bipolar NOS, bipolar 2, recurrent major depression. So I always smile when I hear these debates about, well, this bipolar 2 like bipolar 1. Well, if you're talking about one family, it's the same genetic trait. If you're talking about a whole bunch of different families, then you're not looking at family history, then you can talk about, I guess, different things. But to me, it's all part of the same spectrum within a singular family. So this is the original data sheet from Bastrop and Mogenskau's study. So we already knew at this time in the 60s that lithium was effective for acute manic treatment. The question was, could lithium prevent recurrences in an otherwise highly recurrent illness course? Because one of the things that even Creighton identified about bipolar disorder was the recurrent nature of the clinical course and the spontaneous remission. And so in order to assess stabilization, you have to actually follow a patient past their cycle length. So a cycle length here would be much shorter than, say, here. So you have to make sure that the person isn't in just spontaneous remission and that was actually the drug that brought around the remission. So you can see that in this diagram, dark black is depression, then there's mixed, and then there's rapid cycling and mania. And in patients who had either highly recurrent major depression, which was included in the manic depressive insanity construct in those days, or had a classical episode of highly recurrent course, not rapid cycling or mixed mania, those patients did very well on lithium prophylaxis, and this study was actually prematurely stopped because of the secondary effects. So these patients' lives were radically changed by lithium. But in the current construct, lithium only works for about 30% of patients in the tertiary care system. So when Martin Alda and I left Ottawa and went to Halifax, that was my first kind of academic job, we took over the adult mood disorders clinic in the hospital. And I remember, if they didn't have an EMR in those days, I remember all of the noise of the charts being reeled down, like the corridor for every patient, staff with it. You think like, oh my God, like, and going through what the patient had been on and trying to sort out. So it's really hard now because patients are oftentimes medicated very early on. So you can't really get that nice, untreated clinical course, natural course. And patients are often on multiple medications. And so the question for stabilization isn't to bombard people with medication like in acute situations where you want people well fast. This is around choosing if we could get away with one medication stabilizing, what would that be? So it's a very different question for stabilization. And it's important because most often around 85% of patients with bipolar disorder can be stabilized on monotherapy. So they don't need to continue all the combination of therapies that we might treat somebody with acute mania with, because we want to bring down the acute deficit. So we did this study in Halifax, and it was published with our resident, Michael Passmore, and we went through all these charts, and Martin came up with the ALDA scale, so in the original study, we treated all of those patients with lithium, and they had to be on lithium stabilization without a recurrence, with adequate blood levels for at least 3 years. So we did this clinical work in the tertiary care center to identify lithium responders and non-responders. And it was just good clinical practice because those patients came as quote unquote refractory, and we could stabilize most of those patients and change their lives forever. And that's why those patients actually really bought into the research with us, because they said, wow, you guys have really helped us. So, but what we found in Halifax, we came up with the Alder scale too, and it was so many points for quality of response to those who've been treated with lithium, minus points for any co-medication, or we didn't know what the clinical course was before, so any uncertainty around whether it was the drug stabilizing the patient or not. So it's a very pragmatic clinical study, and we found that around 30% of patients were excellent lithium responders in current or care pathway. So either they were more psychotic spectrum because we had broadened the diagnosis and focused on mania for the diagnosis rather than the tracheum and recurrent course, or they were more bipolar 2, comorbid anxiety, substance abuse. And these patients do better on lamotrigine. It used to be carbamazepine before lamotrigine. These patients do better on atypicals, and then you've got the lithium responders. So that's just really important for clinical practice. It's also important for research, because one has to think that probably those patients that respond to lithium, which has a very different underlying pharmacology, and also it turns out very different neural correlates, probably they have a different illness, although we call it bipolar disorder, than the people who don't respond to lithium and respond to atypicals that respond to convulsant. So this is a slide from Martin, and it's showing differences in neuroimaging correlates with lithium responders versus and convulsant responders. This is a study we did and published looking at familial clustering of lithium response using the Alder scale. So you can see these are excellent responders here. And this is a study with the International Group for Lithium Treated Patients that we did, looking at the stability of effective morbidity index for lithium treated patients over years. So lithium doesn't lose its effectiveness in patients who really respond to it. And you can actually even, I shouldn't say this because it's not guideline driven, but we've even brought patients off lithium to give their kidneys a break and take them back on and monitor them with DSTs for high risk times. So that's only in lithium responders and only if you're following those patients very closely. So this is from the paper that Paul and I just published, and it's kind of like our view on what we've learned from studying these families across generations. And you can see the real difference in different disorders that segregate in these families. So this is the lithium non-responder, the more psychotic spectrum, a whole much more variable presentations, more chronic. And these are the lithium responders and much more recurrent mood disorder problems. So that's kind of the fact there with you. Now, the high-risk study, so when I was a resident, as I said, I had a half day to practice, and we could involve ourselves in ongoing research. So that was an amazing opportunity, and started working with these families and interviewing the adult members for genetic studies, which is an amazing opportunity for diagnostic learning. And then we would meet and consensus the diagnoses blindly. And then I started to study the children, and we took all consenting families with children aged 5 to 25. Basically I did a semi-structured interview with them. We reviewed the interviews blindly and described the psychopathology that we found in the children. Later, as I continued with this work, we wanted to explore underlying risk mechanisms and work with various people from around the world on different imaging, neurobiology, epigenetics, and psychologists on psychological markers and targets, and then with mathematicians on individual risk prediction. So this was the first paper from this work that was published in the American Journal in 1998, and that was as I just finished my residency. And there's a lot of interest in this because we really were the first out of the gate in family studies of bipolar parents. And there was I didn't know it at the time, but there was a Dutch study started by William Nolan and Catherine Reichardt that was just coming along behind me that ended up being really important because they independently replicated the findings that we had, right? It also started to question what was coming out from the Harvard group with Biederman and Wozniak at the time, talking about prepubertal mania. And we actually didn't see any prepubertal mania. So that's what started this whole 2 decades of debate with Harvard around, we didn't see that in our highly loaded families. Like, how come you guys are seeing that? So what we did find was that the lithium responders had sort of normative or gifted early childhood functioning, whereas the offspring of lithium non-responders oftentimes had abnormal, like psychosocial academic functioning, much like you'd expect children of schizophrenic parents to have. And then much later, there's this excellent study by colleagues in Denmark who used registry data to identify parents, so a real epidemiological study as opposed to a highly selected for genetic research study. And they found the same. They've independently replicated our findings as well, showing that offspring of children of schizophrenic parents have neurocognitive, neuromotor deficits, whereas children of bipolar parents tend to look normal. So then I continued on and got a postdoc award from OMHF, and then kept going with the study. And we saw that the different disorders in the 2 groups of high-risk offspring were more variable than we expected. We certainly didn't see that in the adult, but that it was even more variable in the offspring of more psychotic spectrum bipolar parents. So you can see ADHD, learning disabilities, and psychosis NOS was much more prevalent in the offspring of psychotic spectrum bipolar disorder, like its classical form. So this is the Danish study, and essentially they found the same thing, that more neurodevelopmental presentations were in the offspring of schizophrenic parents. This is a kind of later paper, basically looking, now we've looked over years. So now we're sort of in, almost 10 years down the road. And these more kind of varied presentations in early childhood started morphing into or evolving into mood disorders. And then the Dutch study, somewhat later, published a very similar finding. So it's really nice when things are completely replicated. It's like, oh, awesome. And now we get into, and this is the time when we started saying, well, we have these highly penetrant families. So if there was something such as prepubertal mania, we would see it in these families. And prepubertal mania came from observations in Harvard of children referred to a psychopharmacology clinic who had ADHD, were mostly male, and had really explosive temper and dysregulated. And so we started debating them on this, and I'll get to that in a minute. So the other thing that we found, as we had more kids developing mood disorders, was that those early, quote unquote, non-specific childhood presentations in these kids at genetic risk for bipolar disorder predicted mood disorder later in adolescence at a much higher rate than you would expect. And so it seemed to me that these antecedent anxiety, sleep disorders, they weren't just garden variety anxiety that we see in young children. They actually seem to be the early indicator of the bipolar diathesis in these kids. And so that was really interesting to us. And it happened much, much earlier than the mood disorder. So it wasn't a prodrome. This is showing that the first 5 diagnosable full threshold mood episodes were primarily depressive in nature. So again, that was important, harking back to Rudder, where we looked at a developmental perspective. And as adolescent psychiatrists, the message is you've got to be mindful to ask about the family history because it can present as depression. But what is the likelihood that this young person, if we were to put them on antidepressants, might have a paradoxical response, or if they might really briskly respond beautifully, but then you need to take away the antidepressant because then you could end up with rapid cycling or flattening creating chronic dysphoria, actually. So depression predominated the early course of bipolar disorder in both subgroups, more so in the lithium responders. We'll think of that. And these were highly recurrent episodes. So very much kind of like the parent in terms of the highly different course. So that this was about, we were also publishing on the genetic work and showing that there were different genetic correlates associated with lithium responsive bipolar disorder. And what was really interesting was the way that we orchestrated the DSM. If you add up the lifetime diagnoses between these two subgroups, you wouldn't get much difference. So let's say there's sleep and anxiety problems that lead to depression that lead to bipolar disorder. But what you're missing in all of that is the very, very different nature of the clinical course. So what struck me was these kids would come in for their annual research interview and they go, oh yeah, I was really depressed last fall and I thought about calling you and then I got better. But it wasn't like overnight. It was like, I was really depressed for 3 months. I went to the family doctor. We were discussing medication. And then by the time we got round to it, 5 months later, I started to feel better. And so, whereas these kids, once they started to get ill, they never really got back to baseline. They were always symptomatic. They could be acute exacerbations, but there was always something going on and happening and not well and layered kind of problems. And then this gets us to this is great, sorry. This gets us to the British Journal paper. Now, I was asked to write a paper, invited to write a paper for bipolar disorder. And I wrote this paper. And after 8 months, it got rejected. And I was really pissed off. And I said, like, why? And it was because of the politics, I think, because they said, oh, well, it's just, we just don't think we want to publish this. Okay, fine, I'll put it in the British Journal. So anyways, I turned it around and put it in the British Journal and they published it. It's been a very impactful paper. But it was because at the time in the US, there was this idea that we were this kind of renegade out there Canadian group that with this lithium responsive weird cohort that nobody could replicate. But we were replicating all over the place. But it was because of the prepubertal mania. Like we weren't finding any prepubertal mania. And this was problematic, right? Because then there was a whole case where a child unfortunately died that was on carbamazepine. So it was very political. But it ended up to be, I was so glad. So when things don't seem like they're going your way, maybe they end up going your way. So this ended up being an important paper, and it was really modeling. It's working with Charlie Kuhn, who's been amazing. He was a national student in statistics at the time, and I said to him, I want to test a model of progression. Like, are these really progressive stages? So he did this with fancy mathematics, looking at the question of what is the emergent course of bipolar disorder? What model fits best? And it was the sequential progression that you could enter the model at any stage, but once you entered it, you tended to go forward and not backward. So not everybody gets these early antecedents, about 30% of high-risk kids, so kids at familial risk. But once they do, they're more likely then to develop the next stages. So this is really a great paper. I'm so pleased with it. And then it turned out that what's missing from this paper is the Danish study, which came on board later, but it also found that very similar findings. So the polarity of the first mood disorder in kids who develop bipolar disorder who are at familial risk, they most typically start with depression. The outliers somewhat were the Americans. So this is Biermauer's group now. So Biederman kind of went off, and then Boris Biermauer's group came on with Ben Goldstein. And they were kind of sort of on the fence. So they had sort of mixed findings, but it's partly, I wrote a paper called Methodology Matters. It's partly about where they're getting their families. So the families in the US often volunteer for research because they don't have health care. And when you look at the families in the bio study, most often there's psychopathology in both mom and dad, and often substance abuse. And so these are more chaotic families. The socioeconomic status tends to be lower. And when Boris did a calculation of risk of ADHD, factoring out all of those factors, the kids at risk for bipolar disorder didn't have a higher rate of ADHD. It was more the family milieu that was creating the chaos. So it's really a factor of, you have to think about, okay, who are we comparing with? Whereas the Europeans, they actually had a psychologist, like I was the one blindly interviewing the kids here. They had a clinical psychologist interviewing the kids. And these are very more narrowly defined families. So it's just a factor of how you, and then Martin Prizer's group in Switzerland, that was an epidemiological study, but Martin had a couple of cases prior to puberty of mania. And he went back and interviewed those kids and they were more traumatized. So it's really interesting, right? And so he agreed in the end that prepubertal mania is very, 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 very rare and not really a phenotype related to bipolar disorder. And then they changed the diagnosis, right? To severe mood dysregulation disorder and disruptive mood disorder. So I think we won the debate. So this is now a paper that came out in the American Journal. It's a follow-up to the British Journal paper looking at the emergent course of bipolar disorder after 20 years of research. And we've had enough kids converting to bipolar disorder now to look at the first few mood episodes between the two groups. And you can see this is probability that the episode is suppressive. And you can see that in the lithium responders, the vast majority of first episodes were depressive. And that was still the case with the lithium non-responders, but less so. And you can see that the rate of psychosis was still only about 30%, but much higher within mood episodes and much higher in the lithium non-responders. So this is interesting. So Sarah Goodday, who was Sarah Doucette before she married, she was coming from public health and psychology, and she was interested in measuring symptom level data. She also measured the exposure to early adversity and the risk of mood disorder. We'll come to that. But this is self-report. So this is controls versus high-risk kids using the hypomanic checklist. And the bottom line here is, if you rely on self-report, the kids who had both well parents were not at risk for mood disorders, had higher overall scores of self-reported mania. So in other words, you have to know the population you're administering this to. So if you're giving it to a clinical population and who've had mania, they're going to indicate. If you're giving it to a bunch of adolescents, they're going to go, yeah, like I'm not sleeping. I'm so excited. I fell in love, blah, blah, blah. So it's a different thing, right? But when you use clinical assessment of hypomanic symptoms that don't meet criteria for disorder, those symptoms clinically assessed did predict for mood disorders. So it's just a cautionary note that our self-report, you have to know what the limitations are and what the population is referring it to. So this was the American Journal paper. We looked at symptom level as well as full syndrome level psychopathology, clinically assessed in both cases. And Charlie reran the model, and we were able to show that actually clinically assessed sleep symptoms, depressive and activated hypomanic symptoms did predict for risk, and the sequential model still applied. So it's kind of like coming back. This is from the Dunedin cohort study, where they followed a first cohort of kids in New Zealand forward through adolescence and adulthood, and they were saying, well, what is the relationship of psychopathology to the end stage illness? And they also came up with this idea that psychopathology in children can start it looks very broad, but it goes into, it emerges over development as to where we're going. Except obviously if you have a neurodevelopmental disorder like autism, that we're talking about more like schizophrenia, mood disorders, anxiety. And then there's this whole thing that the next debate was this whole thing about, well, does that mean that there's a pluripotential? Does it mean that we all have these shared risk factors, and depending on what happens to us in the environment, it determines the screen? And I would say no. And I don't have time to go into the evidence for that. But then they started this whole, well, let's come up with a universal staging model. Let's come up with a model where we can just stage psychosis. This is from psychosis now, and adapt it for bipolar disorder. And I was going, well, okay, wait a minute though, but staging is to map onto underlying neurobiology. So how can we just lump all these different illnesses into a thing? if this would work out for nurse managers or some hospital manager who wanted to figure out if we only have so many resources, if everybody would benefit from psychoeducation, maybe we can lump. Do you know what I mean? But it doesn't work for mapping onto treatment or mapping onto studying what is the underlying pathogenesis of this illness. That would be like lumping together different forms of cancer. It doesn't make any sense to me. So anyway, we've been debating this because it would skirt over, like all of this stage one would skirt over all of that trajectory that I talked about, where you could map on, early intervention. So you could, it lumps together all of this until you get here. And so do we really want to study the emergent course as one big block over even so we've been debating that. And then there's some interesting findings. So here's Thomas Pyatt. He was looking at calculating brain age and showing that the brain really doesn't change in those at risk for mood disorders, but of course, clearly there's neurodevelopmental changes in those at risk for psychosis. So this is very much a different disease process. And then looking at the global assessment of functioning in the high-risk cohort, you can see that the lithium non-responders started to drift over time, whereas the lithium responders were still highly functioning despite significant illness when measured that well. This is another of Thomas's work looking at actually our high-risk cohort, a similar high-risk cohort in frog, an early affected high-risk cohort, and then adults with established illness treated with lithium versus not. And you can see that this important region that's implicated in the neurobiology of bipolar disorder doesn't change. This is looking at volume of the inferior right frontal gyrus. Doesn't change, but then as a factor of the burden of illness can change, but be mitigated by lithium. That's very different than psychosis, where we know that there's a change in the neurostructure and neural correlates prior to the onset of illness. And this is just to prove that point that, basically in people who follow prospectively, there's a change in terms of neurocognition and neurodevelopment in kids who develop psychosis versus bipolar disorder, which is more of a burden of illness effect in some patients. So in the last few minutes, I'm just going to talk to you about, well, so what? So what are you doing with all this work? And so this is about the whole debate about pre-pubertal mania. And as I say, I would say that we finally, that's that 20-year debate. And as mentioned, so recently we came out with this position paper laying all out the evidence. And this is where this whole thing came from. So these, as I mentioned, were very, very unwell children who were referred to a tertiary care psychopharm clinic in Boston, who had really a lot of ADHD and a lot have pervasive developmental disorder. You'll see their global assessment of functioning was 43. So these are and you saw that in the high-risk cohort, the global assessment of function was in the 80s. So these are very, very unwell children. And I love this statement. So Gay Carlson called it pediatric mental health care dysfunctional disorder as a better name. And what she was saying is, well, these kids need a diagnostic home. And that's what also was motivating this, because in the States, for insurance purposes, you have to give a diagnosis. And people didn't want to, so they had ADHD, but they didn't know what else to put. So they had all this explosive temper, mood dysregulation, which used to be a part of, prior to GS3, hyperkinetic mood dysregulation. It was a specifier. And then they dropped the specifier, and so they had no diagnostic home. So it became prepubertal mania. But it was really a dysfunction of, but then those kids ended up getting medicated if they had bipolar disorder. So this is just in that paper that we did showing the different course of ADHD with explosive temper and chronic mood dysregulation, and which is much different from the classical bipolar disorder. And this is just showing papers that we've talked about the implications of this high-risk work for diagnosis, that we need to factor in more than symptoms, that the DSM is not helping us, it's hindering us moving forward with looking at mapping our syndromes to pathogenesis, coming up with more novel treatments for targets for treatment, and really moving the outcomes of patients forward. They're not improving. Patients are not improving over time because our diagnoses don't map to individual treatment. And so, Candler wrote that the DSM has moved towards a reification. So since the DSM-3, our field has moved towards a reification of the DSM that implicitly assumes that psychiatric disorders are just the DSM criteria. And so that is, we've taken the index of something for the thing itself. So the DSM was never meant to be literal. It was never meant to be a checklist. It was meant to be a shorthand for clinicians who have done a comprehensive assessment, including developmental history, clinical course, family history. And it's just become a checklist, which is unfortunate. So this is Sarah's work as a master's student. She's now, she was a research fellow at Oxford. She's now an independent scientist in her own right. And she looked at exposure based on our prospective data in the parent as early adversity and outcomes, showing that kids who were exposed earlier on to more unstable parent illness had a higher risk for developing mood disorders. And that was really, I think, an undervalued paper because it was all based on prospective blind observations of the parent course, not the child course. I think it's quite powerful. And so now we're advocating that actually, in order to help children at familial risk, we have to start with the parent. So we have to work with the obstetricians. We have to, work on parents who have severe mental illness who want to become pregnant and make sure that they're well through their pregnancy and make sure that they're supported postpartum, which is really the high risk time for recurrence. And so really the target of treatment for these children at risk is the parents initially until the children are in their own right. And we're working with the UK group to come up with a psychoeducational and CBT intervention for parents with bipolar disorder who have young children. And then here's Charlie's paper on looking at individual risk calculation. So we finally get back to the original question that the parents asked us 25 years ago. We finally have enough data, and we paired with the Swiss group, Martin Preisig's group, in order to replicate this. And it's in a Nature publication, I'm very happy to say. And we have it based on our Youth Flourish website. You can go in and enter your own data and look at your risk of bipolar disorder. We're also using that math to now look at student well-being. So students can go in. We're working with a group at University Hospital Network for Center for Digital Therapeutics, University of San Francisco, University of California, San Diego, and ourselves with Youth Flourish, training on Youth Flourish student data to come up with an individual student well-being and health calculator, which then could map on Youth Flourish. So this is now looking at what did we learn about psychological intervention targets, because kids do not want to take medication and maybe shouldn't take medication early on because if they don't have the full threshold illness, we don't know what the effect is on the developing brain. And so we were working, looking at what was the targets for psychotherapy, and we were able to say high avoidant coping, low self-esteem. And we also worked with Oxford on ecological sampling using digital devices. So we now incorporated that in student wellness research. And then we were also able to map onto recommendations for step-care treatment in kids at risk. We were coming back to the fact that lithium response travels in families, and we were able to show that the stabilizers that worked in the parents tended to work in the kids that needed stabilizers. We got to the point of needing medication. So that's a factor that we should use in our clinical practice. And finally, we come to the paper that Paul and I just did, and it's been such a pleasure to work with Paul. What an honor, and what a great person, and I'm so proud of this work. So thanks for your attention, and I hope you see that I'm not just a researcher, I'm a very big clinician.
So the question is, so it sounds that lithium is a great drug for classic bipolar disorder, but probably not as good for bipolar 2 or bipolar with a lot of comorbidity with anxiety, would you say? And Yeah, actually two questions. One is that, so those patients, let's say, with a lot of comorbidity with anxiety, would they be probably non-responders to lithium or not? And the other question is, lithium is still recommended by the guidelines as a drug for treatment-resistant unipolar depression. But according to your data, that wouldn't make a lot of sense since it's for more of a classic bipolar type, right? It's a good drug for classic bipolar. How do you feel about lithium as augmentation for unipolar depression?
So I've obviously not done a good job of my talk because actually I would say no and no. So what I was getting across was if you look at classical subtypes of bipolar disorder, you have we're not talking about now within families. So if you look at a patient that walks through the door we say to ourselves, okay, what's going on with this patient? And then if we think it's within the bipolar diagnostic spectrum, we try to say, do they look like they have a classical bipolar disorder? Oftentimes predominantly depressive, but highly variable, oftentimes good spontaneous remission, but maybe that's tricky now because they've been given antidepressants chronically, so we're not sure about the quality of remission, but then they have a family member who had a recurrent, so we do our best. So I would say you would try lithium if you're not sure, but you knew it was a bipolar disorder and you couldn't really put the story together, so you should try it. Or if you're very sure that this is a recurrent episodic disorder, so we'll come back to the non-specific benefits of lithium, but as a mood stabilizer. Now, if you're working within families, it really changes because what happens is if you have a classical episodic bipolar patient who responds to lithium, let's say they have a family member who has bipolar 2, I would put them on lithium. Because the likelihood is within a family, within a genetic pedigree, that bipolar disorder, independent of whether it's bipolar NS, bipolar 2, is most likely related to this form of bipolar. So it's just like if we thought about cancer. So if I have breast cancer and my mother has breast cancer, we're going to do the pathology, but it's likely that, and my sister has breast cancer, it's likely that we share. That's right. That's it. Now, so then the other question about refractory depression. So I would definitely, yes, the data is we underutilize lithium as an augmenting agent for either partial response to an antidepressant in the context of depression or quote unquote treatment refractory depression. Because now, if that treatment refractory depression is more negative syndrome and there's somebody in the family with psychosis, then I would say no, probably not. But if there's suicide in the family, if the person's suicidal, if you haven't tried to augment with lithium, then I definitely would. So we know that lithium has an antidepressant effect. We know it also has a non-specific antipsychotic effect. So that's unfortunately what happens with these patients that, we say, oh, they have bipolar disorder. And the guidelines say we should put them on lithium. So then they get put on lithium. Maybe they have more of a psychotic illness. Maybe it does a non-specific dampening down, but the person's really still unwell. And then we add an antipsychotic. Then for me, the question becomes, do they need the lithium? Because maybe they're an antipsychotic responder. But in cases where they clearly were more of an atypical psychotic form of bipolar disorder, which we would have prior to DSM-3R, we would have called them schizoaffective, let's say. Those patients probably can be on an antipsychotic, but we would keep lithium at a low dose only in the case where they were suicidal. Because lithium has an anti-suicidal effect, even in those patients that you're not using it as a monotherapy stabilizer. So it's tricky, right? Because what that paper has done, what we've advocated for is that we use the evidence in our diagnostic approach. So we start incorporating these subtypes in the diagnostic construct. So we incorporate family history, we incorporate quality of remission, we incorporate, this looks like a more classical manic depressive illness, and we should definitely try lithium. But if you're in that other 60% that we're currently calling bipolar disorder, you might not need lithium long term and you could save your kidneys. So it's funny, I've heard Paul say, people will say, well, what do we add to the lithium? And his thing will always be, well, do you need the lithium? Because only a certain percentage of patients will benefit from lithium, but you don't want to miss those because it's life-changing. So if you're not sure, try it. If it's helping, yes. If it's not helping and then you find something that does, then the question becomes, is there an indication to continue the lithium? Even though they have a bipolar disorder. Yes, if there's suicidal, right? Now, oftentimes those patients that in prior decades we would have called psychosis or schizoaffective, let's say those are the patients that tend to, if you just stop lithium but you haven't started an antipsychotic, those patients will get ill very quickly. They'll get that what we call rebound. The classical manic depressive patient, once they're in remission, you actually can take the lithium away. Not that I'm recommending you, but if you did, they would go back to their cycle length. They would go back to their spontaneous course of what will happen. And you can monitor the activity of that illness with the DST in those patients, because the DST will go positive when you get sick. So it's a very different illness, and we've kind of, unfortunately, we've broadened the concept and lumped in a lot of other things into bipolar disorder. So it makes treatment it really is helpful to know the nature of the symptom. But lithium has some important non-specific benefits.
The psychopharmacology course at Harvard about 10 years ago, and that's when a child and adolescent psychiatrist talked about mania in a 5-year-old. I was going, I never heard of such thing, and now I have learned why they were talking about that. My question is, I have a patient who I've followed for years, responder to lithium. It initially developed hypothyroidism, subsequently developed a terrible tremor, and she just couldn't function because of this tremor. This is after years of lithium. And you've identified it clearly for me. She has not responded to anything else I've given her. Lamotrigine, any of the antipsychotics. What would you recommend?
So it is really important with lithium to use the absolute lowest effective dose and to change that over the time with renal functioning, and that often doesn't happen. So, when you look at guidelines, and they're a bit heavy-handed too, I know the American guidelines are heavier than ours even. We say kind of 0.8 to 1.0 millimoles per liter for maintenance. But the reality is everyone's kidneys are different, everyone's different. And people can derive benefits from much lower dose. And the other thing is the plasma level is only an indirect indicator of what actually the absorption is in the cell. So you can do red blood cell levels of lithium, which is telling you what's actually getting absorbed. And as we get older, as we know, unfortunately, our blood-brain barrier gets a little bit more fragile. And our kidneys don't work as well. So it's always really, really important. Like maybe if she was on a very, very low dose, she would still derive benefit, but not get those side effects. So I would be wondering how that, yeah, like even 300 milligrams, like very, very low. Yeah. Thank you very much. Thanks for your attention.